So welcome everybody. This is a panel discussion, but only half the time is going to be taken up with a panel. I'm hoping to leave half the time for you to ask questions. The idea of this is, how do we individualize low-carb diets? So if they are to be effective, how do we use them in clinical practice? I should just say who I am. So I'm a GP, Dr. David Unwin, a GP from the north of England. I've been using low-carb in my practice since 2013. And at the moment, we're getting type 2 diabetes drug-free remission in about 50% of the people who opt to go low-carb, and that's at 2 years. So that's why I'm here. But before we open this up to the rest of the panel, we're just interested to know which healthcare professionals are represented here. So have we got any dietitians in the audience? Great. Have we got any GPs? Also great. Have we got practice nurses? Marvelous. Psychologists? Oh dear. My wife's a psychologist. She's going to be so disappointed. And who have we forgotten that wants to be remembered? Shout out. What are you? Who? Say that again. What are you?
Nutritionist.
Nutritionist. Put your hand up. How many nutritionalists? Woo. Hooray! Anybody else being neglected? DSN. Yeah. Hooray for you. Thank you for coming. Put your hands up. Yay. Have we any consultants of any form? Oh, hello. Thank you for coming. Consultants. How many consultants have we got? One. Well, you're very important. Thank you so much. Thank you so much for coming. So there we are. We are multidisciplinary, and we work together in teams. And we're going to ask each of the panelists about their work, why they're here, and then about tips, hot tips as a clinician, but also are there any pitfalls that they feel that other clinicians need warning about? Because no approach can be perfect, can it? So what could we learn from experience? So if we perhaps start with you, Nicola, would you begin, please?
And you want me to give an introduction to who I am and I guess what brought
me
to low carb?
I would like you to shine, Nicola.
Thank you.
Yes,
okay.
please show up now.
Hello, everyone. So I'm Nicola Guess. I'm an academic dietitian. At the moment, I'm a senior lecturer at the University of Westminster. I'm a research fellow at King's College London, and I'm also the head of nutrition at a diabetes institute in Kuwait. So I live and work in 2 countries at the moment. And really what brought me to low carb is data, and I guess that's what I really bring to the panel. So all of my job is about what works, what does the data show, what's effective. And in particular, I'm really passionate about dietitians. This is hard for me to say, but catching up with data and outcomes. So what you'll see happening, I work with some tech companies who are delivering diabetes prevention, diabetes management. As standard, they collect outcomes data. The outcomes data shows reductions in glycemia and weight. David on the panel has published some work in his own practice about what's happening. And when I talk to dietitians, guys, we've got to be doing the same thing, what I hear is, but we don't have time. And so one thing I hope that comes out of today is if you're doing anything in your practice as dietitians, measure it, collect it, publish it if you can. My second particular passion is using research to address dogma, and that comes a lot with low carb. So I published 2 papers that looked at dietary intake and nutritional intake in patients on low carb diets. Because all I heard from dietitians, and one of my concerns was, but it must be deficient in nutrients. And actually what I found is it's not the case. And fiber is a huge one. Fiber actually was different between a low carb and a high carb diet, but none of the groups met the requirement for fiber. And actually you can have a low carb diet that is sufficient in fiber. So my whole approach is around using data and, dare I say it, facts to help inform care. The second thing I think is really important, because of being head of a clinical service, this might be something other dietitians can relate to, is I think we need to look carefully at reorganizing our services. I'm sure Tara has some comments here. When I was a dietitian in the NHS, I had 30-minute appointments. I really didn't feel like I had much control over what I was doing. What I'm able to do as the head of a clinical service is reorganize everything. So we look at how frequently patients come, we look at DNAs, we change the inclusion criteria of our clinics. We have patients sign contracts. If they're not willing to sign up for a certain package or they're not ready to change, we don't invite them onto the clinical service. And what we've done is reduce DNA rates by 60%. Our weight loss outcomes are improving. Our A1C outcomes are improving. And again, I think as dietitians, we need to take the lead about clinic reorganization. And we can do this with low carb. We can do this with other remission, reorganize our clinics and take a role in clinical leadership. So finally, on to personalization. So because I have an interest in data and research, I have a clinical practice myself. And what I do is I talk to the patient about what does a low carb diet look like? What's food intake like? What does an average plate look like? What are the side effects? What are the bad things about it? What are the good things about it? I do the same thing with the direct, so I look at meal replacement or a very low energy diet, and I say this is what the diet looks like, this is what it will feel like, these are the pluses, these are the minuses, and then I say to the patient, what do you think you choose? So with that, I'll finish.
Perfect timing. Thank you. Tara, please.
Hi everyone, my name is Tara Kelly. I am a dietitian, so I was practicing in the NHS amongst weight management and type 2 diabetes until recently. I'm now a research associate at Newcastle University, so I work at, thanks Ian, I work on the direct trial, and then in my clinical practice, in contrast to Nicola, I came to low carb through my patients. So to be quite honest, I was kind of very much fond of spewing off guidelines and kind of getting frustrated with my patients, thinking, you know, you're not doing what you're told, but in fact a lot of them were doing that. And the reason I started looking into low carb and practicing low carb about 4 years ago now was that a lot of my patients who were coming back to type 2 diabetes clinic with improved glycemia, improved HbA1c, were people who had kind of gone away and maybe found low carb online or heard a friend or a neighbor who had been doing it. So that's really what got me to start then looking at the data, which was really interesting at the time. And I suppose over the past 4 years, I've really kind of honed down on what I feel works well for patients in terms of low carb, and hopefully today we'll talk a lot about the pitfalls as well, and you know, some of the more negative experiences that we've had and how we can hopefully bring that kind of confidence to other people who are interested. Just to mirror what Nicola said, is that I think it's really key, choice is really key, and I've become a little bit obsessed with not just remission, because remission's not possible for everyone, but really improved type 2 diabetes management through lifestyle and giving people options. So looking at low energy diets, looking at low carb diets, and hopefully being able to help other dietitians in their confidence in being able to offer this approach. Because again, to mirror what Nicola said, we as dietitians really should be the ones kind of leading this approach, and we need to beat people like David Unwin with his data, and we need to collect our data.
Beat me.
And be able to really offer that approach. So I suppose over the years, what I've really learned about low carb is really the way you pitch it to your patient. So a lot of people, or some people, not just dietitians, but clinicians might be a little bit wary of low carb. They might associate it with, you know, people putting butter in their coffee and all this kind of thing. That's really not the case at all. And we can look at a really kind of well-balanced, nutritionally complete diet that a lot of patients really enjoy. And the number one thing I hear from my patients is, I can't believe I'm not so hungry. And it's so powerful for them, and they're so in control. They, they're not reaching for that 11 a.m. snack. They're not getting these kind of hunger pangs, and that gives them so much more control over their diet, and it just makes everything a lot easier for them. So I suppose my top tip for if you're speaking to someone about low carb and you've agreed and you've discussed the pros and cons, and specifically for dietitians working in clinical practice, it's really important that you have, you know, a doctor that you can speak to if there's any deprescribing that needs to be done in terms of oral hypoglycemics and SGLT2 inhibitors, and the docs, I'll let them talk about that. But once you want to initiate that with your with your patient, what I find really, really useful is I have really basic food lists. So I have green, amber, and red. The green is full of your starchy vegetables, of your nuts, of your seeds, of your fruit, your lower carb fruit, your meat, your fish, your eggs, your dairy. And what I get people to do is to tick off on this list, of the green list, of all the foods that they like. And before we've even really spoken about the foods they can't have, because I think that's, not a good angle to come at the low carb diet with, they've got a full list in front of them of foods that they've highlighted, and they're looking at it going, okay, I could maybe do this. And what I'll do then is give them a couple of sample meal plans, which will be kind of ethnically suitable and thinking about, and as dietitians, we know so much about people. We know about their lives and their jobs and their stresses. If you can take that all into account and give them something quite positive, a page, it means so much to them, looking down at a page full of green things or, amber things that they really, really think that they can work with. I think just framing that to start, you're onto a winner, and you've got the patient bought in, you're really excited, and just to kind of summarize, I'm really excited now again as a dietitian to have these other tools in my toolbox. So I'm not just spewing off the same advice that doesn't do anything. The patient's frustrated, I'm frustrated. It's so empowering for me as a dietitian to be able to offer these other approaches, to be able to offer low energy diets safely, and to be able to offer low carb. So I'm really excited about today, and hopefully we have some questions from dietitians.
I've got a question already.
Oh God, okay.
I feel it's so difficult for dietitians because of the follow-up. So Kessar and I have the advantage of following our patients up over many years, but how do you address the problem of follow-up as a dietitian with patients?
That's a really good question, and I suppose it really depends on all of us in our clinical practice, how often you can follow up a patient, and sometimes you just physically don't have the capacity to see them. What I always did in my busy NHS clinics was always give an email or a contact number for someone to be able to contact me if I couldn't see them again. But I just want to touch on what David said earlier about teamwork, and this really is about the team. And if you have the GP engaged and I can't see you for 6 months, what a great opportunity for the GP to say, oh, and how's that, how's your low carb diet going? So if you can get the GP or other clinicians or healthcare professionals involved in the care, it's almost like if we could work together, they can help you with that follow-up. So I think that's really useful to do that as well.
Thank you. Kessar, please.
Thank you very much, David. And before I start on myself, can I just echo the teamwork approach? This is the opportunity. And over the last few years, I think there has been some sort of division, maybe separate paths, but certainly on this program, the teamwork approach is going to be a key thing and make life a lot easier. Anyway, coming back to me, I'm Dr. Casey Singh Sadra. I'm a GP in Slough, Manor Park Medical Centre. I've been a senior partner there for 30 years, and I've been heavily involved in type 2 diabetes with my South Asian population. Prevalence of over 15% in our practice in the adult population, and well over 1,200 type 2 diabetics on my list, which I've been looking after. And I've been following the low carb approach for nearly 15 years or so, formally for about 12 years, and I've been achieving probably top ranked achievements as regards HbA1 control with the least expenditure in prescribing over several years. But that's where my, I think, input comes in. And I worked out a program within the practice itself where I use the 10-minute consultation to look after my patients. And I look at their dietary advice, I look at what their sugar profiles are, I actually consult what they want to do and what they want to achieve, and offer them options with their diet, whether they want to cut down on calories or whether they want to go down the dietary measures of reduced carbs. I use graphs, tables, food pictures, and sugar content charts to drive change, and successfully. I've over the last few years, I've actually collated certain pitfalls or difficulties that patients have, particularly in the South Asian population, which can be perceived as an incredibly difficult population to make change in. and I've tried to get answers as to what we can do as clinicians, as practices, to try to get them approaching and agreeing or developing changes which are beneficial. How are we doing for time?
You've about another minute, Kessa.
Wow. Now, very briefly, the actual difficulties that I've observed is that there's been conflicting recommendations and guidance, whether it's from fellow GPs, nurses, dietitians, and the Diabetic Center. In order to address that, building trust is the key thing, and explaining the basic physiology in a culturally sensitive way, where the elderly people who don't get that access to that information so easily, you can actually relay that information through to them. And as a result, you also ask them to maybe try various maneuvers with their diet and be accessible within a few days, if need be, over the telephone, to see whether they're comfortable with it, whether they've achieved something. And if they've got the reassurance that you're going to be accessible, they will try it. If you're going to see them after about 2 to 3 months, the chances are they will lapse and they will not continue. And that's probably the key thing.
Kessar, if I was to give you another 30 seconds,
yeah.
I think your expertise in Asian diets is of great interest to many people. Have you got any hot tips for how to help people give up rice or other things?
Sure. I've actually collated a lot of pictures, colorful, tasty, appetizing, mouth-watering pictures of foods, plates, which I have at hand. And depending on what the individual is eating day by day, morning, afternoon, or evening, there are certain pictures that do spring out and suggest. And the question to the patients is, what do you think of this? Do you think it is something that you could eat? And they usually, their eyes are opening and they say, yeah, a bit too much more than me. The alternative, basically what I focus on is salads, reducing the chapatis or the rice. I use dishes of cauliflower rice as well, and pack the plate full of the vegetables and the meats or whatever else that they do eat. I personalize the response to what they're eating in order to get the change. I don't have standard statements or pictures what I suggest to them. I first ask them what they eat and then come up with suggestions what they can change to, whether that's at breakfast, whether that's at lunch, whether that's in the evening meal, whether that's at home when they're by themselves, or out in a social function, which is usually quite a complicated thing. But it's finding alternatives which are appealing to them, appetizing, palatable, and practical. You know, if those four statements are not fulfilled, patients will find it difficult. But if those four factors are considered, I think they find it much, much easier.
Kessar, thank you. So I've got 3 minutes left. Individualizing, I think people's hopes are individual and different and worth exploring. And time spent looking at what people hope for is time well spent. I think the next thing is, what form of feedback would that patient like? Because changing behavior, we need feedback, and feedback individualizes stuff immediately. How will you know it's working? Are we measuring waist circumference? Are we measuring weight? Hemoglobin A1C? What is it that we're going to measure? And I agree that with the patient, then they get feedback. A Freestyle Libre might be feedback, and that can have amazing effects for some patients very, very rapidly, the power of feedback. I think the other thing that is choice, isn't it? Is choice. As a healthcare professional, our job is to help people make choices, but they have to do that in an environment where they understand the physiology. So some of you will have heard me speak earlier today, and I can explain to a 73-year-old or a student or an unemployed person or an 80-year-old about insulin and glucose and where it comes from. And that helps individualize diets for people to make their own choices about what they're going to eat based on their goals and based on the physiology that I've explained to them. A couple of points I wanted to make. I think as the low-carb movement matures, we have to be honest and say there are dangers and pitfalls. And the value of experienced doctors like me is that you don't have to make the same mistakes that I have made. And one thing that's uppermost in my mind at the moment is, what about patients who are already on medication when they go low carb? Is it safe or is it not safe? We published a paper, Campbell Murdoch and I published a paper in the British Journal of General Practice about 3 months ago on exactly this subject, and it's open access so that any clinicians wanting to know what are the issues with a particular drug and going low carb I hope you would look at the paper. There's a very useful table on there. There's one drug I would like to highlight, and that is the SGLT2 inhibitors, because they can bring about a particularly worrying form of diabetic ketoacidosis. The point is it's euglycemic, so the blood glucose may be normal. And I've had a case where that was initially missed because the blood glucose was normal and the clinician felt that probably they didn't need to worry. If they're on an SGLT2 inhibitor, it may be a normoglycemic event, and that some of these people can be very sick. So bear in mind SGLT2 inhibitors. I would, of course, make the point that SGLT2 inhibitors just help you wee out sugar you shouldn't have eaten in the first place. But then again, I would say that, wouldn't I, really? A couple more points. If you have a patient who is losing weight, but the hemoglobin A1C is rising, you should worry. You should worry. That's clinically unusual. And it can very occasionally be something like either a misdiagnosed type 1 diabetes, or it can be carcinoma pancreas, something like that. So somebody is losing weight and the hemoglobin A1C is going up. That's very unusual. Clinically, what nearly always happens is weight goes down, hemoglobin A1C improves. So that would be odd. Another thing that's been missed on a couple of occasions is somebody with a hemoglobin A1C of, say, 30, and they're not well. I wonder if anybody in the audience could shout out what might be wrong with that person. Somebody knows the answer. Somebody's got a hemoglobin A1C. All right, hemoglobin A1C of 28, and they're not well. What's happening? Yes. They're anemic. Well done. So many people forget that we are talking hemoglobin, and if you don't measure a full blood count along with a hemoglobin A1C, you could miss a carcinoma colon of somebody that's bleeding, and they're losing weight, and the hemoglobin A1C is going down, possibly, but they're sick. They're sick. So bear in mind, this is what being a clinician is about. It's about, we have value because we have clinical experience, and that means as we get older, we learn stuff. So this is why we're all valuable in this room, because clinicians, we're not talking leaflets. We're individualizing our approach, and that's what expertise is about. I think my final point before we go to generalized questions is I've been looking at patients where I fail. I'm very interested in why doesn't it work? And talking to people and looking really carefully over the long term. Many patients improve, and then at about a year, they're starting to slip. My wife is a clinical psychologist, and she's done some early work looking at 1,000 patients, and we find that food addiction, and certainly carb addiction, is a real problem for maintenance of behavior change. And I think this needs some more thought. Are the patients addicted to carbs, and is this why they're slipping back? And do they need a different form of help, or how can we help people with carb addiction? I don't know the answers to any of these. but it's one of the problems I faced most often. If I fail, it's somebody who's slipping back, going to bread or whatever, and they've really struggled to do without it. So I think that's my last little worrying thing. One of the points I was just going to ask the dietitians about was, one of the things we did in the early days, thinking about multidisciplinary working, I think group work, group consultations could be really good for low carb and diabetes, and that could enable a very different way of working together. So I wonder if either of you could have any comment on group work and low carb.
I mean, yes. So this goes back to what I was talking about before in terms of clinical leadership. So when I was a dietitian in the NHS, like I said, we had 30-minute appointments, 15-minute follow-ups. What I would end up doing at the end of every appointment is just handing a patient a slip. They go to reception and they book an appointment whenever it happens to be, and it's 3 months later. And as you correctly said, we know that's not going to work. If you see a patient once and you see them again 3 months later, they will not have changed anything. They probably won't come back. So what I've been able to, and what I think we should do as clinical leaders, is reorganize our clinic, and that takes data. So with regard to groups, we've had mixed success with groups whenever we tried it in the NHS. Some populations seem to like it, some don't. But, so how do you decide to do it? Well, what about getting some data, putting out questionnaires to the patients? Or if patients don't show up, give them a ring. Why didn't they show up? The other thing that we've been able to do in our clinics in Kuwait is, again, use data. So we looked across at attendance, individual attendance for every dietitian. And typically what we get is a spreadsheet with each person coming maybe twice a year. So often they come once and they DNA. Sometimes they might come once and then come back 3 months later and then DNA. And so we want to discover, well, why is that? And so we put out some surveys, we rang the patients, and a lot of it was things like, I just forgot about the follow-up appointment, I didn't feel like the advice was valuable. And some of it was, I'm sure many dietitians will recognize this, I went to the dietitian because the doctor referred me, but I wasn't really interested. And this is something we have power over as dietitians. So when I worked in the NHS in East London, we recognized this, that many doctors just referred the patient shows up, no idea what you're going to say, they don't feel ready in their life to change anything, and you as a dietitian are wasting your time with that patient, the patient's wasting their time, and it's wasting funding. So what we did in the NHS and what we do in our clinics in Dasman is we basically have a contract, we have a discussion with patients. This is the kind of stuff we're going to talk to you about doing. Do you think you could do more exercise? Do you think you could reduce carbohydrate? Whatever it might be. And if they say, oh no, well, what's the point? So by, and this sounds harsh, but eliminating those patients, we don't have them come into the clinics until they're ready. We free up time. What can we do with that freed up time? Well, we can see them in 2 weeks. And what happens when we can see them in 2 weeks? They get great outcomes. So they come back. And going back to the group question, I was getting to this. Groups is a great way for people who want to get some dietary advice, but that maybe they're not so ready to make massive changes. So those patients who kind of show up, maybe they're newly diagnosed, we put them in a group. And we're doing the same thing with low carb. Finally, with remission, we have a remission clinic. We use low carb, meal replacement, time-restricted feeding. We get them to get into remission, then we have group-based follow-up. And we save our time as clinicians, and that's why we can see more patients more frequently, and we're getting better outcomes.
So just to finish up on groups, my practice has been doing group consultations since 2013. And the first thing is you need 2 clinicians to run a group, I would say, so that you can support each other. But it also really gets you off to a multidisciplinary start, and you learn from the other person. But then you learn so much from the patients, and we've ended up with a lot of patient experts now who actually are teaching the clients more than I do.
Yeah.
And it's so exciting when patients explain to other patients how you do this. And it's very restful for me. I go home from those meetings. They're not tiring. I go home energized. I've just seen loads of heroes working. It's really great fun. So that's the end of us chatting. We're going to open the questions. And I know that Ian is going to ask the first question. He's there.
Oh, is he? Yeah.
Yes, Ian.
Yeah, thank you. Ian Lake, I'm a GP. Thank you for the presentation on low carb in mainly type 2. I have type 1 diabetes. Do you think, from your experience, that low carb diets have application in type 1?
Right, each of us we'll try to get through more questions. If you want to, somebody else wants to be ready with that microphone. So Ian was asking, he has type 1, and he wants to know what do the panel think about the opportunities or threats of low carb in type 1. I've been really surprised by how people with type 1 diabetes are very different to type 2. They're really used to handling serious situations, manipulating, changing their insulin. They're very grown-up people. They've had a lifetime of managing this. So in my clinical practice, I have found that on average, somebody with type 1 diabetes will reduce their insulin usage by about 50%. What they really appreciate is that they feel they have more control and they probably have fewer hypos. That's not research, but you did ask, and that's my clinical experience, and it's emboldening me because I was so worried about them as a group, but I have to say they've done better than I ever knew they would, and I'm certainly offering it more often now. And I think particularly when you attach that, as we can now on prescription with the Freestyle Libre, you've got a reasonably safe thing. They're very grateful, very effective, and so far, touching wood many times, it's just brought me joy because they don't really need much of anything. They just come back and say, right, I'm on 50% of the insulin, thanks a lot. I don't need to see you for a while, but shall we do a hemoglobin A1C? And then when I do the hemoglobin A1C, it's generally dropped by loads. So good question. Could we have the next question, please? Who's got the microphone? So just, thank you.
So Dr. Unwin this morning. I'm a pharmacist, also a type 2 diabetic, and today I had my results checked downstairs, and my HbA1c is 42.
You'll need to hold the microphone nearer to your mouth and just tell us the last bit again.
Okay, my HbA1c is 42 millimoles.
And what was it before?
It was 54 in June.
Well done. How much weight have you lost?
I've lost 2 stone.
Wow.
Well done.
I've been following the low carb diet.
Yeah.
And I've been doing fasting as well, and with learning through Dr. Michael Mosley. And I've also kind of like seen what you mentioned about, what the doctor mentioned about tables and charts.
Yes.
So I seen something that hit me was when I saw a patient who was diabetic and was amputated. And that really like made me scared and gave me fear, but then it gave me hope.
Yes.
And that's the final message I want to say is that for me, I want to become a GP like Dr. Unwin, so that's my next goal.
Oh.
And he's my
Remember,
idol.
I'm very old and bald.
He's my idol, and I mentioned that on
Bless
Twitter.
you.
So
I think the message of hope is so important. It's so much more powerful than fear, is what I'd say. Thank you. Thank you very much.
you're welcome.
And now who wants to... This has to be a question for one of these three because I'm speaking too much. That's amazing. Well done.
Well done. Really good job.
Patrick Rowland, GP Lincolnshire. When you talk about low-carb diet...
Could you just say which of the three people here you want to ask the question
as opposed to the two dietitians. And I don't know, possibly...
Dietitians, right?
Anybody, I mean... Because the question is, when you talk about low-carb diet, are you saying they shouldn't be eating any carbohydrate at all? Or you mean reduced portions? And when you talk about carbohydrates, what exactly are you talking about? Are you talking about things like rice, potatoes? How about things like pasta, spaghetti, couscous? And then moving on to other components of diets, like the proteins, meat in particular. And also, are you advising your patients to stick to things like chicken and fish, or can they eat beef like anybody else? And then, do you counsel them on exercise as well, or you just focus on diet? And then, how does that interact with the medications?
Yes. Good question, and we have two dietitians ready and waiting.
Okay, there's quite a few questions there. So just to cover the first one, when you mentioned about what we actually mean by carbohydrates. So a low carbohydrate diet is not a no carbohydrate diet, and that's something I think we all need to be very clear on. I personally, in my practice, and this is a practical session, so I'm going to tell you what I do, is I usually aim for about 100 grams of carbs a day. And it will really depend on the patient in front of you. So some people want to count carbs. They want to, be methodical and know exactly how much. Other people, just telling them to cut out starches or agreeing with them to cut out starches, say your bread, your rice, your pasta, that works very well. And some people don't want to count at all. When we think about the carbs that people generally do have on a low-carb diet, or what I personally encourage, it's certainly things like your vegetables, your leafy greens, your nuts, your seeds. A lot of people enjoy having a bit more dairy, full-fat dairy. So it depends on the person in front of you. The technical term we use for a low-carb diet is about less than 130 grams a day, but this is all about individualizing again. And I've had some patients who've actually, just about cut down on their starches, but cut out all the added sugars and the fizzy drinks. And for them, that's made a huge improvement. So it really is about the person in front of you, and kind of being honest with them. You can try this or you can try that. I personally find, as I said, though, cutting out the starches is quite helpful. And again, the feedback, if you can at all, or if any of your patients with type 2 have access to a freestyle or even just a blood glucose meter, and they can test, even just for a day, just one day, to test postprandially after they've had their porridge or their banana or their Weetabix or whatever it is, and if they can physically see themselves that their figures go into double digits, that's more powerful as a behaviour change tool than any of us sitting here telling someone what to do, I think. Yeah. The second question was about... Sorry? Exercise. Yes. So certainly for myself, I'm not a physiotherapist or anything, but I would always encourage exercise. It's incredibly good for managing blood glucose, incredibly good for cardiovascular health. It depends on the person. If you've got somebody who really isn't into exercise, or if they're not physically able, even if they can do 10-15 minutes of activity after a meal, that can really help. I know Dr. Sadra has some really interesting or really useful graphs, and I actually do the same, as I show people graphs of postprandially what's happening to people's glucose, and then what can happen even if it is just a 10 or 15 minute walk after a meal. So again, individualizing. If it's somebody who's really keen for exercise, I would really encourage it, but even if it is just 10-15 minutes after a meal, I would encourage that as well. Sorry, David.
Thank you. Now we've got time for one more question, and this question must either be for Nicola at the end or Kesar, because we must be fair and hear from everybody. So is your question for Nicola or Kesar? And if it is, put your hand up, and we'll let the gentleman with the mic decide who looks friendly. Hello.
Hello, Doctor.
Tell us who you are.
I'm Josephine. I'm a retired midwife and nurse, and I lost 6 stone with the help of my NHS dietitian that works with bariatric surgeons.
Well done. And your question...
She doesn't realise that it was actually low carb, but that's what it turned out. Right,
So
if
who is
my
your
daughter
question
was
for?
pregnant, she could choose her doctor if she wanted a home birth. Can't the government change things so that people that want to lose weight can choose their healthcare professional?
Okay,
and
who
pay them?
who do you want to answer that? We've got Nicola or Kesar.
I think it needs both of them, because
right.
my husband would love Dr. Kessar, because my husband's from the Middle East.
Right.
If I was asking for dietary advice, my husband might prefer me to go to a lady.
Right. Okay, Kesar, you can go first, and then Nicola. So I think the question is why can't people choose who they go to for their advice to do with diabetes? Is that fair? Yes, right, Kesar. Why can't people choose?
I think we are more and more, agreeing with choice. As long as the patient or the individual is informed of what the options are, is very clear what the options are, then they should have a choice. So I think times have changed a lot compared to the previous years. I mean, yeah.
I'm going to answer it like a politician, sorry. I think a huge problem is the gulf in expertise and the gulf in maybe knowledge or experience that people get when they go to see different, even GPs, even dietitians. There are good ones, bad ones. I think that's a huge problem. I've had many patients who've been referred to me because maybe they were type 1 actually. They were low carb, doing great, and they went to see a particular GP or a particular dietitian who said, oh my God, what are you thinking? And that to me is maybe a bigger problem, that we need to upskill everyone so everyone knows as much as possible about all this stuff. And then regardless of where you are geographically, your chance of getting someone who can really support you and do a great job is greater. So I know that was kind of dodging your question, but I think that's something important we need to deal with.
I think, have we used up our time now, or have we got any? Can we have one more question? We can have one more question. And so please tell us who you are, and then direct your question at one of the panels so they pay attention and the others can go to sleep.
Hello, yes. My name's Indra Nathan, diabetes dietitian from London. My question is...
Who is the question to, please?
To Nicola.
To Nicola, right.
Or any of you. But we get a lot of patients asking about ketogenic diets. I'm just wondering how low would you be comfortable with the carbohydrate, for a low-carb diet?
Okay, great question. So I think there are two things that are important here. One is the diabetes control, and I don't think you probably necessarily need to go lower than 50 grams to get amazing diabetes control, especially if the patient has type 2 diabetes and loses weight. But the advantage, and I think Tara alluded to this, what we know is with ketogenic diets, the production of ketones, so even the meal replacement, a very low energy diet, you start oxidizing fat, you produce ketones, that suppresses appetite. So that's kind of another element of it. So with a lot of patients with type 2, particularly obese, I'm happy for them to go crazy, crazy low. The lowest I have is probably 30, 40 grams. Let me be very explicit, I encourage non-starch veggies exactly the way Tara does. I'm actually quite liberal with fruit. What I say to a patient is have a full meal, never snack on fruit, don't have it on its own, but have a full meal, feel free to have a piece of fruit afterwards. Then when they come back, we look at the A1C and go from there.
Thank you. So that's the last question. I think I'd just like to point out how amazing it is for me to sit on a podium like this and in a room full of interested people fascinated by low carb, and we represent so many different specialities. It's got to be a hopeful message, because a few years ago I was totally alone, and now look, I bet there's 150 of us in this room. This is definitely a growing thing and a maturing thing, and I'd just like to thank you so much for showing interest. And before I finish, we will be hanging around a little while. I'm sure some of you might want to come up and ask questions. So thank you so much for coming. Thank you very much.